Hello friends, I hope you all are doing fine. So let's start. Today's topic is multiple sclerosis. As we all know, it is the demyelinating disorder, means it will affect the myelin sheath. So it is the demyelinating disorder. What are the so today plan is uh, it will be just an introduction type uh, lecture of multiple sclerosis, because it is a wide topic. Its diagnosis is basically its treatment is very important. So I will take the treatment lecture, and the diagnosis lecture will be separate. Today I will cover the introduction and some of the clinical features and the types, which are again very important. So let's start. So multiple sclerosis, it is an autoimmune disease. So it is more common in the female as any other autoimmune disease. It is more common in the female. Female is to male ratio is 3:1. Other characteristic features involves it is in chronic inflammation, and chronic inflammation will consequently will lead to the neuronal loss, gliosis, and demyelination. So what is gliosis? It is in a reactive inflammation of the glial cells. Okay, so it is an autoimmune disease characterized by the chronic inflammation, will lead to the neuronal loss, gliosis, and demyelination. Okay, so it is an polygenic inheritance. There are many factors: environmental factors, genetic factors, and various other factors like HLA DRB1 1501 is the HLA which predispose the patient to the multiple sclerosis. Okay, so we should keep in mind this HLA, because it is an for MCQ purpose it is very important. Okay, so epidemiological features are, as I already told, that autoimmune disease, so more common in the female than the male, mainly occur in the adult population 20 to 40 years of the age. And because that one type of MS, that is primary progressive, that is occur more in older age, after the 40 years. Okay, so typical type of MS is usually occur between 20 to 40 years of the age. Okay, more common in the white population, so it is very rare, or very rare in the Asian population, Asia, Africa. One variant of multiple sclerosis, that is opticospinal variant, that will occur in the Africa and Asia, but the typical variant more common in the white population. Okay, so where is this factor of multiple sclerosis? We have to keep in mind there are vitamin D deficiency, cigarette smoking, and remote EBV infection. These are the risk factor for multiple sclerosis. Okay, and one is that HLA DRB 1501. Okay, so risk these are the risk factor for multiple sclerosis. So very important type of the MS. So initially there was we were aware that there were 4 types, but now it is having the 3 types. Okay, 3 types. What are the? Relapsing MS, secondary progressive MS, and the primary progressive MS. Okay, so relapsing MS means it recur again and again with time. Okay, and the in between the patient neurological features, patient is asymptomatic. Okay, like we can understand by this graph that this is the neurological symptoms, and this is the time. So with time, patient having worsening of the neurological feature, then again normal, then again attack, then normal. So this is occurring again and again, recurring attack. This is the most common type of the multiple sclerosis. Okay, one term we can use for this, that is DIT, dissemination in time, and other term is also there, dissemination in space. These 2 terms are very important for the multiple sclerosis. I will teach you in detail later on. Okay, so first type is relapsing MS. Second type is secondary progressive MS, means initially patient was having recurring attack, in between the neurological symptoms were normal, but with time the patient is deteriorating, and progress its neurological features start worsening with time. So initially it was having recurring attack, and then secondarily it progress. So with the name only we can understand. Okay, so this is the secondary progressive MS, and it is mainly having that is benign course only. Okay, so the third and the last type is primary progressive MS. We should keep in mind this because it 10% of the cases are having primary progressive MS, and it is having very bad prognosis. Okay, very bad prognosis because it causes much disability in the patient, and it progress very uh, 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 fast, or there will be steady decline of neurological function. So patient will be more disabled, and it is usually late onset, and usually it occurs equally in male and female. So these are the feature of primary progressive. And one more reason of bad prognosis, that only the treatment which we are use there are various important drugs which are we use for the treatment of MS are not much effective in the patient of primary progressive MS. Only one or two drug I will teach you later. So it is having bad prognosis. Male is to female ratio is equal here, and it is usually late onset, and more patient will be more disabled. It steadily neurological function decline over time. So ठीक है. Now please keep in mind there are three types of multiple sclerosis: relapsing MS, secondary progressive MS, and primary progressive MS. Primary progressive MS is having bad prognosis. Relapsing MS is most common type. Okay, so pathological features. Pathological feature we will not go in much detail. We just have to superficially know about the things. That is, it involves both cellular as well as humoral immunity. So B cell as well as T cell mediated process or pathological pathological association is there. So these cells, B cells, like macrophages and other inflammatory cells, are usually perivenular in location. Okay, so that is this called as perivenular cuffing. This will lead to the blood brain barrier disruption, and this blood brain barrier disruption will appear as gadolinium enhancement in the MRI. Okay, I will teach you later during the diagnosis that what is gadolinium enhancement and how to appear, or in much details. Okay, this macrophages and all will be located perivenular, and this will lead to the blood brain barrier disruption, and this all the inflammatory process will lead to the demyelination there, and there some of the surviving oligodendrocytes will remyelinate the axons and will try to remyelinate. That is, partial remyelination will occur, and that is appear as shadow plaques. Okay, so these are the various terms we should keep in mind, like perivenular cuffing, blood brain barrier disruption, shadow plaque, black holes. There is black hole, I will teach you later. These are some of the terms we should keep in mind in the pathological features of the multiple sclerosis. Okay, now the clinical features. Clinical features are this term I have told you already, the dissemination in time and dissemination in space. And these terms are regarding the symptoms of the patient, presentation of the symptoms of the patient. Dissemination in times, and that is recurring course. It is different time, different features, or so this is the dissemination in time. And dissemination in space means various topographical areas of the brain, like patient one time patient may simultaneous features. Patient have the optic neuritis, and the patient is having the facial palsy or the facial weakness. So these are the two areas, topographically unrelated areas are involved. So it is involved the dissemination in space also. Okay, I mean different area of the brain is involved, like we will see the in the diagnostic criteria later on. So just keep in mind that there is some term is this, and what is the mean of what we understand by these terms. Okay, so let's see. So the clinical features is the most common symptom is sensory symptoms. Okay, sensory symptom, patient may have pain, paresthesia, or any sensory symptom is there. These are the most common patient is sensory symptoms which the patient is complaining about. Okay, then there is the optic neuritis. We should keep in mind this is unilateral. Okay, monoocular. So unilateral optic neuritis is there because we have to differentiate MS from the NMO and the ADEM. So there optic neuritis is bilateral. So we should keep in mind that in MS optic neuritis is unilateral. Okay, so here optic neuritis is unilateral, and patient will have some color perception defects. Central color vision may be affected. Okay, but complete loss of vision is very rare in this patient. Okay, it is very rare. Now the patient will have the weakness, and weakness is mainly the upper motor neuron type weakness. Patient can have the facial palsy. So facial palsy, we have to differentiate if the assume that the patient is present with the facial palsy, that we can say that the patient may have the Bell's palsy. So we have to differentiate this facial palsy from the Bell's palsy, that is facial palsy of MS and the Bell's palsy we have to able to differentiate. So there are the two features which can be, we can say, are the differentiating feature between these two. One is the facial palsy in MS will not be associated with the retroauricular pain, and there will not be the loss of taste sensation. As we all know that in the Bell's palsy, taste sensation will be lost, and patient may complain of retroauricular pain. These two features are not present in the facial palsy or facial weakness in the multiple sclerosis. Okay. The another feature is spasticity. Nearly 30% of the patient will have spasticity, and it is exercise inducement. Spasticity will be worsened when the patient will do exercise. Okay, and the most again the important feature is diplopia. Okay, diplopia, patient may present as internuclear ophthalmoplegia. Patient may have horizontal gaze palsy or acquired pendular nystagmus. Okay, so what is INO? I hope I will take the some other small lecture on the INO, because we have to understand this. Okay, internuclear ophthalmoplegia, it occurs due to ipsilateral MLF lesion, medial longitudinal fascicular lesion. Okay, I will teach you this later on. Okay, so diplopia here in MS, INO is bilateral. Okay, so it may present as INO, horizontal gaze palsy, or acquired pendular nystagmus. And again trigeminal neuralgia, glossopharyngeal neuralgia. Here one again important thing is trigeminal neuralgia. We have to differentiate it from the again we have to differentiate it from the trigeminal neuralgia. There it is proximal features, and proximal features, no objective sign of sensory loss is there, and that is mainly unilateral. But here in MS, trigeminal neuralgia is maybe bilateral, occurs less than 50 years of the age, and sensory loss is there, and the symptoms are not proximal. So we have to differentiate between the typical trigeminal neuralgia and trigeminal neuralgia in the multiple sclerosis. Okay, so this also we have to keep in mind. And patient may have glossopharyngeal neuralgia, ninth cranial nerve also involved, facial myokymia, like the rippling of the muscle, and mainly the lower lid muscles, orbicularis oculi, the lower lid is mainly involved. Okay, so there are two symptoms, Uthoff symptom and Lhermitte symptom. Uthoff symptom are heat sensitivity, means when the patient will do exercise or any hot water shower, or the in the fever, there will be more symptoms of the patient symptom will be exacerbation will occur, and this is a pseudo exacerbation, so no need to use the steroid here. So when the patient will have the fever, patient symptom will exacerbate, but this is the pseudo phenomena only. Okay, so Uthop phenomena or Uthop symptom we should keep in mind, and one is Hermit symptom, that shock like sensation down the spinal cord when the patient flexes the neck, and this is again is not the specific for MS, it also occur in cervical spondylosis. So these two symptoms we should keep in mind. And the bowel bladder symptoms are the bowel, mainly the patient will have the constipation more than the incontinence. Okay, and the bladder involvement is again very common, will again manifest as bladder dyssynergia and all the symptoms. Okay, bladder symptoms are also very common in the patient of multiple sclerosis. Patient can have ataxia, vertigo, hearing loss, can have sexual dysfunction, cognitive dysfunctions, and depression is more common than the euphoria, and fatigue. This is the we should keep in mind, this is the we can say most common work related disability in the patient of multiple sclerosis. So these are the we should keep in mind all the clinical feature of MS. This is very important, and we should differentiate between the facial palsy and trigeminal neuralgia, which occur in the MS and occurs in the Bell's palsy and typical trigeminal neuralgia. Okay, these are so let's wind up this. Thank you. I hope I am able to contribute some of your learning. I will try to make simplify later on, and next class we will do the diagnosis and the treatment of multiple sclerosis. Okay, let's revise what we have learned in the very short manner. Okay, it is an autoimmune disease, it is various characteristic features, it is having polygenic inheritance, epidemiological features, females more than the males, more common in the white. These are the risk factors, and again 3 types: primary progressive bad prognosis, or relapsing MS most common. Again the pathological both B and T cells, perivenular cuffing, and the shadow plaques, demyelination. Dissemination is patient time. Most common sensory symptoms, most common symptom is sensory symptoms, and again INO, diplopia, trigeminal neuralgia, facial palsy, Uthop symptom, Hermit symptoms, and depression and fatigue, most common work related disability. Okay, so please read this, and if any other point or any doubt, please feel free to ask in comment, or please give your valuable feedback, so can I improve my teaching, or we can contribute to each other learning. Okay, thank you.